Good afternoon, everyone. Welcome back. So for the last leg of our lectures this afternoon, I will start with an interesting topic. I know that it's more of our specialty as an infectious disease specialist, but we would like to share with you the development on HIV, especially the prevention of mother-to-child transmission of this infection. Worldwide, adults and children are estimated, these are the estimated number of adults and children to be living with HIV. And the leading continent for HIV infection is actually Africa, then followed by ours, Asia and the Pacific. With this data, 3.2 million children worldwide are actually living with HIV. And most of these children are actually infected by their HIV-positive mothers during pregnancy, childbirth, or breastfeeding. Our local data shows, so you look on the table number 1, or the quick facts of our HIV data in the Philippines, which is actually underestimated, because we all know that HIV infection still has that stigma between patients and the other people, because if you have HIV, you have to be, it has to be a secret, okay? So, but look at the data in 2013, showing us that the cumulative data shows that the total reported cases are just actually about 16,000. And the females here, I want to focus on the females are around 1,946. These female patients may be on their childbearing age, and so they can give birth to babies. And these babies are the ones who will be susceptible for the HIV infection. The data here for children less than 15 years old is actually 65. It's still underreported. Okay? And the mode of transmission for most of these cases is actually the mother-to-child transmission. So, mother-to-child transmission of your HIV infection is through vertical transmission, through, number 1, in utero across placenta or in the amniotic fluid. Number 2 is during the birth of the child via direct contact with the blood or infected maternal, cervical, and vaginal secretions, and then postnatally. And the third one is through breast milk. I'm sorry for the small font for this table, but this study shows us that the maternal and infant risk factors contributing to HIV transmission to the infant. Let's look at the maternal risk factors are the following: high maternal viral load, high vaginal or cervical shedding of your HIV virus, and the low maternal CD4 count, and then the presence of maternal genital ulcer disease. For the infant, those who are premature or less than 34 weeks of age, and in utero or intrapartum vaginal delivery, okay, with prolonged rupture of membranes, chorioamnionitis, or there's presence of instrumentation. Postpartum, the infant can get it through breastfeeding, especially non-exclusive breastfeeding, or through mixed feeding, or if the mother has a breast disease like mastitis or cracked bleeding nipples. such that the first step to interrupt your maternal to child transmission of HIV is to identify those at risk, the mothers, the pregnant mothers who are at risk, so that they may be provided with therapy and then information to decrease the risk of infection to their infant. Now, in 2006, HIV testing has now become a routine component of prenatal screening tests. The key element here is the concept of your opt-out testing, whereby the testing is performed unless the patient would decline. It is actually the same as, for those of us who got pregnant already, you are being tested for VDRL. Diba? So it's like HIV testing should also be part of the routine. And the separate written consent for HIV testing should not be required, and then therefore should be part of the general consent for medical care. This data is actually from the WHO guidelines on HIV. This is the latest data of the year 2013. Now, actually, the existing recommendation there is that the provider initiated testing and counseling is recommended for women as a routine component of the package of care in all antenatal, childbirth, postpartum, and pediatric care settings. Regarding the highly active antiretroviral treatment in women, or what we call now the HART, okay, it is recommended for all pregnant women, including women who do not require treatment, in order to optimally prevent perinatal transmission and then minimize the risk of maternal development of resistance to ARV. So all pregnant women with HIV are now being treated, with the goal being for women to have undetectable levels of HIV-1 RNA virus. I have shown you earlier the table that the load of the virus is one of the risk factor. And then a minimum of 3 drugs is actually recommended even for women who would not otherwise require the therapy. They are HIV positive, but they have very good or very low viral load or very high CD4 count, but once they get pregnant, they have to be treated. So this is the recommendation from WHO that a once daily fixed dose combination is recommended as first-line ART in pregnant and even breastfeeding women, including women in the first trimester of pregnancy. And many studies have shown that treatment of pregnant women, even in their first trimester, does not affect the child or have any adverse event on the baby. Okay. Regarding the cesarean section delivery, I have shown you earlier that vaginal delivery increases the risk of transmission of HIV to the child. Thus, elective cesarean delivery prior to the rupture of membranes would actually reduce the risk of your HIV transmission by half compared to vaginal delivery. And studies have shown that from US and then in Europe, of more than 8,000 mother-infant pairs, that the likelihood of HIV transmission, HIV-1 transmission was actually lower than with any other modes of delivery, with around 50% efficacy, 57% efficacy. Thus, the mechanism of in risk reduction is actually thought to be due to the reduction in the infant's exposure to the contaminated maternal blood and vaginal and cervical lesions, thus lowering the maternal-fetal transfusion. Okay, regarding breastfeeding, I know most of us would actually react on the breastfeeding, but we all know that breast milk it substantially increase the risk of transmission of your HIV-1. And so in settings where avoidance of breastfeeding is feasible, affordable, and culturally acceptable, actually it is recommended that the mothers would stop breastfeeding. In Thailand, they have adopted, their government, through the support of their queen, actually adopted the no breastfeeding policy for all women, or for all infants born to HIV positive women. But they actually provide the milk for the first year of life. Okay. Thus, exclusive breastfeeding, so the choice is either you do exclusive breastfeeding or not do the mixed feeding. So exclusive breastfeeding has been found to have significantly lower transmission risk than mixed feeding. Mixed feeding is giving of breast milk and then formula milk. Okay, because in several studies in Zimbabwe, that shows that introduction of the animal milk, so that is not from humans, or solid foods before the age of 3 months is actually associated with 4-fold greater risk of perinatal transmission at 6 months of age. And also in the South Africa study, mixed-fed infants also receiving solids, remember they would start giving cereals or porridge, were actually 10 times more likely to acquire the HIV infection. This is actually thought to be due to the disruption of the integrity of the intestinal mucosa of the baby, which is actually protected if you are just giving them breast milk, and thus allowing HIV, the virus, to more readily penetrate these microabrasions if you are doing mixed feeding. So it's either you do exclusive breastfeeding or exclusive formula feeding. Okay. So this is now the recommendation for the babies and even the duration of breastfeeding. Mothers known to be infected with HIV and should exclusively breastfeed their infants for the first 6 months of life, and introducing the appropriate complementary foods thereafter. So they are actually delaying the giving of the solid foods, and then continue breastfeeding for the first 12 months of life. And breastfeeding should only be stopped once a nutritionally adequate and safe diet without the breast milk can be provided. So this is also the new recommendation of WHO, that infants of mothers who are receiving ART, so the mother should still be, if the mother is breastfeeding, so she should still receive the ART. And should receive, and those infants now breastfeeding should receive 6 weeks of infant prophylaxis with daily nevirapine, or the NVP. Okay. Now, let's go to the ARV prophylaxis in infants. The landmark study by the pediatric AIDS clinical trial groups showed that the mother-to-child transmission of HIV could be reduced by as much as 2/3 with a regimen initially of sidovudine, okay, your AZT, okay, prior to and during the delivery, and to the infant after the delivery, for at least 6 weeks. Okay, and the introduction, and then it was followed by the newer drug, the nevirapine, for a single dose, daily dose, in resource-poor settings. And this is supported by the study on HivNet in Uganda that showed that the single dose of your nevirapine regimen as it results in therapeutic levels in an infant for at least 10 days, could actually provide protection to breastfed infants in the first week or two of life. And as breastfeeding is the nutritional norm in most of Africa and the other less developed countries like the Philippines. So we are actually advocating breastfeeding, thus this could be our recommendation. So the simplified infant prophylaxis dosing recommendation is already in the guidelines. Now, it would depend on the weight of the child and also the age of the child. Okay. Now, I'll be presenting the scenarios, the different scenarios that these patients may come to you, okay, in your clinic. No? So the scenario is, number one, the mother diagnosed with HIV during pregnancy. So your OB partners will now be referring to you these babies, no, to be born, and they have, the mother is already diagnosed with HIV. So maternal, so the second column shows that the maternal ARV prophylaxis should be initiated. And infants, once they are born, should be started with nevirapine. And the duration of the infant prophylaxis is for 6 weeks. Now, the second scenario, the mother is diagnosed just during labor, okay, or immediately postpartum. Di ba? Yun usually yung scenario natin. Ay, na-test yung mother because it was routine in your hospital and the mother is not actually consulting in your hospital, and then immediately you have the result showing that the mother is now HIV positive. So for the mother, you initiate the treatment, and for the infant, you start also the prophylaxis. And then the duration is actually still at 6 weeks, but you may have to consider extending this to 12 weeks. Okay. The first scenario is that the mother plans to breastfeed. Okay. And the third column there is the mother plans to have replacement feeding. So you have to refer the mother for HIV care and then evaluation for treatment. But the infant still has to be given your prophylaxis for 6 weeks. The last one in this table, the infant identified as HIV exposed after birth, through infant or maternal HIV antibody testing, and then is breastfeeding. Again, you have to initiate the treatment of the mother because she is breastfeeding, and the prophylaxis for the baby. But the duration, the thing here is you have to perform infant PCR early, for early infant diagnostic test, and then immediately initiate the 6 weeks of your nevirapine, and strongly considering extending this to 12 weeks. The last two scenarios, your infant identified as HIV exposed after birth, but the mother will not be breastfeeding. Okay, then you can actually refer the mother for HIV care and evaluation for treatment because she's not going to breastfeed. And this is the difference now. The baby may not be started with the prophylaxis, but you have to do the HIV PCR test in accordance with the national recommendation for early infant diagnosis. Okay? And then initiate the treatment if the infant is then infected. So the last scenario is the mother is receiving the ART, but interrupts the treatment during her pregnancy and even while breastfeeding, such as in cases of adverse drug reactions to the mother, or there's stockouts of the drug, or refusal to continue the drug. So for the mother, you have to determine an alternative ARV treatment or solution, and then counseling regarding the continuing of your ART without interruption. And for the child, then, you have to start the child with your prophylaxis until 6 weeks after the maternal treatment is restarted, or until 1 week after breastfeeding has ended. Now, the HIV testing of infants. Now, these infants, HIV-exposed infants and children younger than 18 months should be tested at 4 to 6 weeks of birth. Where do we do the testing? That's the question here. No? There are several HIV treatment hubs. Okay? And also, although I cannot tell you where outside of Metro Manila, the other laboratories, but here in Metro Manila, we do it in these all treatment hubs. I'll show you the list later. So, serological test is actually not recommended for infants because we all know that serological tests would only test for antibodies. And the antibodies that you may see, no, may be from the mother, okay? And this may persist up to 15 to 18 months of age. And we all know that mortality is very high among untreated infants infected with HIV in the first year of life. Thus, we have to test the infants as early as possible. So the definitive confirmation is your virological test. These tests or the assays detect the viral nucleic acid or the DNA or the RNA of the HIV or even the P24 antigen. It's very specific. Okay. So the algorithm actually is there on the guideline for early infant diagnosis. You can access this in the WHO website. Just type on the HIV guideline. So it's there. You can actually download it as a PDF file. Okay, so HIV-exposed infant or child less than 18 months of age, you have to do the diagnostic viral test. And so this will show you if that is not available, there are other things that you can do, and if it is available, then this it's either positive or negative. This is the continuation of the algorithm. Locally, we started meeting with the DOH actually, and by 2013, and then the 2014, I don't know yung date, September of 2014, we came out with an administrative order on the subject, the policies and guidelines on the use of your antiretroviral therapy among people living with HIV and HIV-exposed infants. So it is included here because we all know that the treatment, all our treatment hubs and our DOH is giving all the ART drugs for free. Okay, so it's free and it's available. Okay, so the mandate for these treatment hubs, through its HIV/AIDS core team, or what we call the HAC team, should, number one, conduct adherence counseling to people living with HIV prior to and while on ART. They also provide the treatment. That's why I told you, even the nevirapine prophylaxis for the infants are free. Okay. And the clinical monitoring of these patients under ART. And they would actually provide technical assistance even to other healthcare facilities and community-based organizations in need of the professional trainings on clinical management of HIV infection. So you don't have to actually look for pediatric infectious disease specialists in your area. No? Because if you have the treatment hub, then you go to that treatment hub. And then they would actually respond to the referrals from various health facilities. And then they should submit the reports. So now this is the list of treatment hubs in the Philippines. There are only 18 treatment hubs in the different regions around the Philippines. But I'm hoping that we can have more of these treatment hubs in the Philippines, so you can go and refer all your patients to these treatment hubs. So meron ho ba sa inyong region? Hopefully, and even the contact numbers are there. Okay. So, I have told you about the importance of the risk factors of maternal and infant risk factors. And we all know that the leading risk factor for maternal to child transmission is the presence of the maternal plasma HIV RNA load. So the priority is decreasing the viral load of the mother to undetectable levels by the time of delivery. So how can we do this? Number one is universal provision of testing. The opt-out, I told you about. So I hope we can actually partner with our OB society so that your hospitals or even the different clinics would actually include HIV testing to all pregnant women. And then, if they are diagnosed to have HIV, then the Arv prophylaxis during pregnancy is very important. And then, give them the option of cesarean section delivery prior to labor and the rupture of the membranes. Then after the baby is born, okay, you have to counsel the mother on safe replacement feeding or exclusive breastfeeding, and then followed by the ARVs for the infant in the neonatal period. And we hope that HIV transmission can now be reduced to less than 2%. Actually, it was initially 10% for global, but for us, we do not have the data yet for the HIV transmission. But just to share with you that in PGH, since 2009, where we started the HIV treatment hub for children, we have at least a total of 19 referrals of babies being born to HIV-positive mothers, and only one had positive testing because the NRV or the mother initially was not treated and the baby was not given the prophylaxis. All the rest of the 18 babies that turned out negative were given the prophylaxis, and their mothers were also given the ART. Okay. So, which among these babies have HIV at birth? Tahimik ka. Which among them? The answer is, you cannot tell. Because HIV infection, they don't have the FACI, they don't have the syndrome, they don't have anything at all. So the thing is, we have to recognize that and partner with our OBs that they have to tell us if the mother is or if the infant is exposed, and then we can start with the prophylaxis, and then these babies will actually grow to be the normal child. Okay, so I hope we are now aware that we have this program in the Philippines, and that you are now aware of your treatment hubs in your region. So prevention of HIV actually begins with each one of us. Thank you very much.